Hi dear all, let's all try to talk about cardiopulmonary interactions in a mechanical ventilation settings. So what is it? You have the patient's heart and lungs interacting with the ventilator to provide a different outcome than that is expected when the patient is spontaneously breathing. So for us to know what the differences are, we need to know some physiology. Why do we breathe? We need tissue oxygenation, right? That is what you want at the end of the day. Not just you breathing in oxygen and breathing out carbon dioxide, but ultimately you want the end result, that is tissue oxygenation. So here you have your lungs, and here you have your right side of the heart, left side of the heart. And your right side of the heart receives blood from the peripheral veins to the central veins to the right atrium, which goes into the right ventricle. Through the pulmonary artery, gas exchange happens in the lungs. It ends up in left atrium, from left atrium to left ventricle, and then into the major vessels, and then into the rest of the vessels to your peripheries. So what enters into your right atrium through your peripheral veins is your preload. Okay. Then you have your lungs doing the work of oxygenation and ventilation. Then you have your right ventricle pumping out the blood into the aorta against the pressure there. So putting it all together, you have some amount of volume that is coming out of the left ventricle as a function of the existing preload, the ability of the left ventricle to contract, and afterload. This stroke volume with the number of times the heart pumps is going to give out the cardiac output. Correct? So in a mechanical ventilation, we are not much concerned about our mechanical ventilation affecting your heart rate, but we are more worried about the changes that it might do to our stroke volume. Got my point? So this is one basic that I want you to understand. So stroke volume varies as a measure of your preload, contractility, and afterload, and cardiac output is stroke volume into heart rate. Now you want oxygen delivery to tissues, correct? So what is oxygen delivery, or what determines oxygen delivery? Oxygen delivery is dependent upon the cardiac output and the arterial oxygen content. How much oxygen is there in the blood? It's not just enough that blood circulates, you need oxygen in the blood, correct? So how do you calculate the oxygen in the blood? You calculate it as 1.34 into hemoglobin into saturation plus 0.003 into PaO2, where your PaO2 is the dissolved oxygen, and this hemoglobin calculation mentions the hemoglobin which is bound to oxygen, percentage of oxygen that is bound to hemoglobin, right? So what are the conditions that can decrease oxygen delivery to tissues? If you look at this formula, anything that reduces cardiac output, or anything that reduces the oxygen carrying capacity of the blood or arterial oxygen content, right? What will decrease your oxygen delivery, your cardiac output? It is stroke volume decrease or heart rate decrease. What can decrease stroke volume? Either a decrease in your preload, decrease in the contractility, or increase in afterload. These are the three conditions which can result in reduction of stroke volume. What are the conditions that can reduce the arterial oxygen content? If the hemoglobin is less, or the saturation of the hemoglobin is less, or if the dissolved oxygen is less. Dissolved oxygen usually is not a problem, because in the equation this is very minimal. So what you can do from your side is to improve the hemoglobin content and improve the hypoxemia or the saturation of oxygen, correct? To improve the cardiac output, ventilator matters. So that is what we are going to discuss. So this end of the equation of oxygen delivery you can manage by adjusting the inspired oxygen concentration or the pressures and your hemoglobin concentration. To manage this part of the equation in oxygen delivery, there are some things that you have to know as to what happens when a patient is put on a mechanical ventilator. So why is it important? Normal spontaneous ventilation, what do we know? Inspiration is negative, correct? Expiration is positive. Whereas in a mechanical ventilation, it's a positive pressure ventilation that we give usually in our pediatric ICU settings, acute care settings. Positive pressure ventilation means what? It is positive pressure, right? Inspiration is positive, inspiration is not negative, and the intrathoracic pressure is generally transmitted into the pleural space. And transmission of airway pressure is greatest when the lung compliance is high and least when the lung compliance is low. Imagine if you are holding a balloon in your hands and somebody is blowing on the balloons. You see that the pressure is transmitted from the balloons to your hands. Why? Because balloon is compliant. Suppose somebody is blowing on a say football or a basketball. You see that the pressure is transmitted but not as easily as that of a balloon, right? Why? Because the compliance of the football or the basketball is low, and that is what happens. So, this pressure transmission is important for all of the mechanics of your heart to work properly. If you look at this, so on the x axis you have your left ventricular volume, and on your y axis you have your left ventricular pressure. Okay. So, let us start from this point on. So, this is the point where the mitral valve opens. So, if mitral valve opens, volume is going to enter from the left atrium into the left ventricle, correct. So, left ventricular filling happens throughout this period. So, this filling is representative of preload, okay, and the preload is dependent upon the volume and the diastolic compliance. If the left ventricle is stiff, if the left ventricle is not going to yield, then the amount of volume filling is going to be less. If the volume that is coming in itself is less, again your left ventricular filling will be less, correct, makes sense. So, when it comes to point B, your mitral valve closes and then the pressure steadily rises as the ventricle starts contracting. Here there is no change in volume, correct, the volume is steady here, but there is contraction resulting in increased pressure. This is isovolumetric contraction. If you can recall your physiology days cardiac cycle, this was one of the phases, right. And then at a certain point you have your aortic valve opening. So, once aortic valve opens, the blood rushes out of the ventricle at a higher pressure into the aorta, right. So, this is your ejection. This left ventricular ejection is dependent upon the contractility and the afterload, alright. So, after the aortic valve closes, your ventricle relaxes, but there is no change in volume again. So, this is isovolumetric relaxation with a drop in pressure. If you see, this point to this point is your stroke volume. So, that is why we discussed stroke volume is ultimately dependent upon your preload, your contractility, your afterload, alright. So, let us see how things vary. We will discuss one by one. We will see what happens to the right side and the left side, and your preload, contractility, afterload. So, preload. As far as preload is concerned, the changes are similar between the right side and the left side. So, let us start with atrium. So, preload is the degree of ventricular stretch before contraction, and it is dependent upon Frank-Starling's curve. Frank-Starling's curve we have been reading again throughout physiology, right. So, under physiological conditions, the amount of stretch is going to be equivalent to the amount of contraction, right. So, this is the preload in the x-axis, and y-axis has stroke volume. So, under physiological conditions, if you see, there is a steady rise with increase in preload, there is an increase in stroke volume too, right. But after some point, if you see, the stroke volume remains same despite increase in preload, correct. So, this part where it is curving upwards is the preload sensitive area, where an increase in preload is actually going to increase the stroke volume of the patient, whereas the flat plateau is the preload insensitive part, where even if you are going to increase preload or increase volume, it is not going to translate as an increase in stroke volume, So, what happens in a mechanical ventilation? So, this side you can see in a normal spontaneously breathing patient, let us put it that way. The patient has, or the person has, a negative intrathoracic pressure during inspiration. So, this negative intrathoracic pressure is going to do what? This is going to do this, correct? This is going to bring the walls of the atrium away, meaning the pressure inside is going to drop. So, this pressure drop compared with the increased pressure in the periphery or peripheral veins is going to push the blood towards your atrium, right atrium to be specific, correct? So, you have increased venous return ultimately. So, if there is increased venous return on the right side, then you expect that under physiological conditions, the same amount of blood is going to come to your left side also, correct? What is going to come out of right side, you expect it to come back to the left side. Okay, so this is a normal ventilation, where normal spontaneous breathing, where the inspiration causes increased venous return. Imagine a positive pressure ventilation. Okay, so this side is your positive pressure ventilation, where with positive pressure you have pressure coming inside, and this is going to push the walls in. And when the walls are pushed in, you have an increase in right atrial pressure, and the pressure inside here and the pressure outside in the peripheries, the difference is less. Okay. So, how will flow happens? Flow will happen from a higher pressure area to lower pressure area, right? From a higher resistance area to a lower resistance area. If the pressure is too much on the incoming area, the right atrium, how do you expect the veins to empty completely here? So, you end up actually reducing the preload. Okay. So, positive pressure ventilation reduces the preload to right atrium. What happens in the right ventricles? So, again on the left side you have a spontaneous breathing, where there is negative intrathoracic pressure pulls the ventricle apart outside, right, resulting in a more compliant ventricle, resulting in easy receiving of the blood from the right atrium. The pre-systolic volume increases, basically because right atrium receives more blood, right, more preload, it enters into the ventricle also easily. On the other hand, in a positive pressure ventilation situation, where the walls are going to be compressed, this again will add to decreased capacity of the ventricle to receive the volume, in addition to the already reduced preload, resulting in decreased pre-systolic volume. Okay. So, at the end of the day, you have decreased preload in the right atrium, resulting in decreased pre-systolic volume in the right ventricle. So, this is going to go back to your left atrium as decreased preload and decreased pre-systolic volume in the left ventricle, and ultimately you end up having a decreased cardiac output. Okay. So, mechanical ventilation or positive pressure ventilation on your right hand side results in decreased preload. Preload reduces with mechanical ventilation. So, let us put it that way. Okay, preload does not matter for left or right, difference does not matter, but ultimately it reduces. If you want to put this as a flow chart, you can say like this: increased intrathoracic pressure causes compression of the right heart, resulting in decreased venous return, that results in decreased right ventricular stroke volume, which translates as decreased blood into left ventricle, ultimately resulting in decreased cardiac output. If you want to represent the same as a graphical format, where you have pressure on the y axis and volume on the x axis, the center one or the gray one that I have represented here is your normal stroke volume. Okay. So, this is your normal stroke volume. For the same afterload and same contractile diastolic conditions of a ventricle, if suppose the preload is reduced, you have reduction in stroke volume, correct? For the same afterload conditions and same diastolic contractile conditions, if you are able to increase the preload, then what happens? You have an increase in stroke volume. Okay, so for if the other conditions are going to remain same, increasing preload in the correct area is going to result in increased stroke volume, whereas decreased preload is going to translate as decreased stroke volume. This is the same graph that we saw before. Now we are just representing the preload here. So preload we are completed. Now coming to afterload. Afterload is different for the right side and the left side. Okay, because the right sided afterload is determined by your pulmonary vascular resistance, whereas your left sided afterload is determined, to put it simply, by your blood pressure. Afterload is the amount of work that heart has to do to eject blood, and ventricular wall stress during systole can also be called as, or you can label it as, the afterload. So what is this ventricular wall stress that I am talking about? Any contraction, no, it increases wall stress, and that is your transmural pressure, pressure inside the ventricle versus the pressure outside the ventricle, the difference. And there is usually a balance, just like how you have alveoli and your pleural pressure, your transpulmonary pressures, etc. Similarly, you have pressure inside the ventricle that is trying to push it outward, and you have your pericardial pressures and your transmural pressure that is trying to push the ventricle inward. Okay. If you want contractions, you want these two to be more than that of your pressure in ventricle. But in standard conditions, you want both of them to balance each other, so that ventricle neither collapses nor becomes over distended. All this wall stress is dependent upon your law of Laplace. This is just out of interest, where the wall stress is your left ventricular pressure into radius divided by 2 times that of your wall thickness. And as we discussed in this small diagram, you can see that the pressure in the ventricle should be equal to your transmembrane pressure and your pericardial pressure. This pericardial pressure increases if you increase intrathoracic pressure. Makes sense, no? See, you have a heart here that is covered with pericardium, and you are going to give positive pressure. So positive pressure is going to what? Push this inside, right? So your pericardial pressure is going to increase. So is that good or bad? Ultimately that is what you want to know, right? So with this equation, if you see, you want your ventricle to generate enough power to pump, right? So you want say, imagine your pericardial pressure of around 5, okay. You want your ventricular pressure to be 120. So in that case, you want your transmural pressure to be what? 115, right? 115 plus 5. Imagine a situation where the pericardial sac is being compressed, resulting in rise in pressure. And say this rise, this has risen from 5 to 20. So if this is 20, you want your ventricular pressure to be 120, then your transmural pressure or the actual myocardial contraction needs to generate only 100 millimeter of mercury. That means it's actually less stress for the ventricle. Am I right? You got my point. So you want the ventricle to be less stressed, and that is what your positive pressure ventilation does. So in positive pressure ventilation, your pericardial pressure increases. So left ventricle need not work that much, it can work less. So positive pressure ventilation on left side decreases left ventricular afterload. In fact, you can consider this positive pressure ventilation as working as a left ventricular assist device, right? So if you look at this graph, a preload and a stroke volume in your x and y axis respectively, for increasing preload you have increasing stroke volume, correct? Under conditions where everything else is going to be okay, if preload is not going to be affected much, your contractility is not affected much. If you have a increased afterload, then you have a decrease in stroke volume for the same amount of preload, okay? So compare these two lines. You have a decrease in stroke volume if there is increased afterload. If the afterload is reduced, you have an increase in stroke volume for the same amount of preload. That is why it is important to improve preload and reduce afterload if you want optimal conditioning for the patient. So, yeah, this is again the same representation in a graphical format, where volume is in x axis, pressure is in y axis. This is normal, where if you have an increased afterload, you have increase in pressures because your ventricle has to work too hard, but the output is not that much, the stroke volume reduces. Whereas if your afterload reduces, you have an increase in stroke volume. This is about your left ventricle. So, for left ventricle, afterload reduces. What happens to right ventricle? Right ventricle, as we discussed, afterload depends upon your pulmonary vascular resistance, correct? So, in a physiologic state where the lungs are normal, let us assume lungs are normal, they have no problem in it. You have the alveoli here, you have the right ventricle pushing out blood into the pulmonary artery. They are coming through the pulmonary capillaries, going into pulmonary vein into right atrium, left atrium, I am sorry. So, now you have a positive pressure ventilation which is going to distend the alveoli. This distension is going to compress upon your pulmonary vessels, right. If you are going to compress upon the pulmonary vessels, it means you are increasing your pulmonary vascular resistance, correct. So, if you are going to increase the pulmonary vascular resistance, it means you are increasing the right ventricular afterload, and right ventricle has to work hard to overcome this increase. Ultimately, your right ventricular stroke volume reduces. Am I right? So, this is a condition where your lungs are pretty okay. But imagine another condition where you have an atelectatic lung or a over distension lung. So, over distension, atelectasis both can cause increase in pulmonary vascular resistance. Let us take this example of atelectasis. So, atelectasis, you have pulmonary vascular resistance increased. If you give a positive pressure ventilation to restore your functional residual capacity, there is more lung recruitment. If there is more and more lung recruitment, then the pulmonary vascular resistance improves. So, once pulmonary vascular resistance improves, you have reduction in afterload. Okay. So, on the right side, you have a increase or a decrease in afterload depending upon what and how you are treating for. It is basically a balance. Okay. Preload, you know that it reduces, and afterload is up to you to see how the patient is responding and manage your pressures appropriately. So, what are the practical implications? So, you have a patient with shock. Okay. So, this patient is having shock, problem is a hypovolemia. So, hypovolemia means there is decreased preload, correct, and your positive pressure ventilation is again going to reduce preload and further reduce cardiac output. So, what are you supposed to do? So, try to fill the volume before you ventilate the patient. Where did I have my notes here? I do not know, but yeah. So, this is the point. So, you do not want the patient to be intubated and ventilated with pre-existing low volume. So, give volume before ventilating the patient. Okay, you do not want this further drop in preload and cardiac output to happen. Next, imagine a situation where you have left ventricular failure. This is something we come across, right? A patient who is in sepsis, multi-organ dysfunction syndrome, has poor cardiac contractility. So, in this situation, there is increased left ventricular filling pressure and volume overloaded state for the patient. So, volume overload means there is high preload. Increased left sided filling pressure means back pressure, increased pulmonary capillary pressure meaning increased hydrostatic pressure resulting in transudation of the fluid resulting in pulmonary edema, right. So, this patient in this volume overloaded state is in a preload insensitive part of your curve. Do you remember the curve where you have this as your sensitive part and this as your insensitive part? So, how much ever you increase preload, your stroke volume is not going to improve. So, what is your aim in ventilating this patient? You plan to reduce the preload. So, simply by giving a positive pressure ventilation, you can reduce the preload for the patient, correct? So, that is why positive pressure ventilation helps in left ventricular failure. It reduces free load, plus it reduces afterload also, right? For left ventricular side, it reduces afterload. So, resulting in easy ventricular contractility. So, your left ventricle need not have to work too much to pump the blood, because heart is already tired. Plus a positive pressure ventilation also increases the alveolar pressure. So, if the alveolar pressure increases, the amount of transudation of fluid reduces, resulting in decreased pulmonary edema. Again, as we discussed earlier, a positive pressure ventilation works like a left ventricular assist device. All the more important to us, because if you have a child whom you are ventilating for left ventricular dysfunction, especially on extubation, or if you are planning to extubate, you have to be very careful, because the ventilation, positive pressure ventilation has been supporting the left ventricle by providing all these extra perks. Okay, so if you extubate the patient fast or early, you are going to devoid the patient of the assist help. So, the patient can end up in a very bad condition, very bad left ventricular failure. And please note that, do not say I have given a extubation trial with pressure support, patient tolerated well, but after extubating patient declined. You will still be giving pressure support during most of your extubation trials, right? So, that will not give you an idea if the patient is going to tolerate your extubation or not. A T-piece trial may help, because T-piece is generally without pressure support, and you will know if the patient will be able to tolerate a condition of ventilator. Okay, but that is a topic in itself again. So, yes, so we discussed these conditions. So, in conclusion, see, left ventricular, right ventricular preload reduction results in a left ventricular preload reduction. A right ventricular afterload increase can result in left ventricular preload decrease, resulting in decreased output. Right ventricular volume overload can result in left ventricular preload reduction. So, all are interconnected. Okay, so all are interconnected. Left ventricular afterload reduction is good, because left ventricle will be able to pump better. But right ventricular afterload, if it increases too much, then the output reduces, then left ventricular output also reduces ultimately, right? Because what is coming in itself is less. So, everything is interrelated with each other, and we need to understand the patient as a whole. You should stand by the bedside of the patient to determine what is happening, and not just look at the numbers and manage the patient. Last but not the least, let us just touch upon this one topic. So, you have your right ventricle and your left ventricle. So, imagine if the patient is having a fighting with the ventilator, the patient wants more breath and you are not giving breath. So, patient tries to take a very deep breath. So, deep breath, spontaneous breath means increased negative intrathoracic pressure, resulting in increased right ventricular volume, because there is increased venous rhythm. This sudden increase in volume can result in bulging of the wall into the left ventricle. So, what happens? So, increased right ventricular preload causes intraventricular septum bulge. This results in a smaller volume of the left ventricle and less compliant left ventricle, resulting in decreased filling and decreased cardiac output. Again, importance for us to let the patient breathe comfortably, okay, how much ever he or she wants. Hence, avoid dysynchrony. So, this is in short about your cardiopulmonary interactions. We can't cover everything under your cardiopulmonary interactions, but this is just the basic, and I urge you to go ahead and read good articles about it to understand better, understand cardiopulmonary interactions in different pathological conditions also, so you know how to manage a patient. Thank you guys for listening to me patiently. Share it among your colleagues if you find this useful. If I have made any mistakes, please feel free to point out. I will also update it in the description box below. Thank you, bye bye, and all the best.